As you know, viral resistance is based on the quasi-species nature of HCV in infected patients. Patients are infected by mixtures of different viruses, and very schematically, at the time you start treating a patient, the patient is infected with a dominant viral population, which is sensitive to any drug you give, but there are also pre-existing minor viral populations, generally not detected by population sequencing, that are present. And if you start administering a drug as a monotherapy, this will change the environment into which the virus replicates. This environment will be unfavorable to the sensitive virus that will decline. And the resistant virus, which will have no effect of the drug, will grow and fill in the replication space and become the dominant species. If you stop treatment, you restore the environment that was present before starting therapy, and by doing that, you may allow the sensitive virus to grow back and the resistant virus to become what it was initially, a minor population. But it's also possible that during this high replication of the resistant virus, the virus acquired enough fitness to remain as a dominant species after the end of therapy. And this is all the basis, and this is general concepts that are coming from HIV, HBV, and HCV research. So what happens in terms of resistance with DAA monotherapy? We're not using DAA monotherapy, but we learned about resistance by giving the drugs initially alone. And there are essentially two classes of drugs, HCV drugs. The drugs with a low barrier to resistance, these drugs, when you give them alone, there is a decline of viral replication initially, but after a few days of administration, you see the viral load coming up again. This is the resistant virus, which becomes dominant and grows. And the high barrier drugs are drugs which, when given alone, induce a sharp decline of viral replication. There is no breakthrough. The viral load does not come back. There is immediately a second slope of viral decline that starts even if the drug is not used as a combination. Let's first discuss the three classes of drugs that have a low barrier to resistance, and the first one are the NS3 protease inhibitors. As you can see here, the mode of action of the NS3 protease inhibitors is to bind tightly to the catalytic site of the enzyme and block its catalytic action. And you understand very easily that any amino acid change in that region around the binding site will alter the capacity of the drug to bind into this site. And therefore, the virus which has a mutation will be resistant and will be able to cleave the polyprotein. This slide is a map that was built by the HCV drag group, which shows the sequence of the NS3 protease, the different classes, subclasses of protease inhibitors here, and different mutations that have been shown to confer resistance to the protease inhibitors. And as you can see, there are mutations that confer resistance to all drugs in the class. They are cross-resistant. This is a case of mutation at position 155, 156, 168, 170. And other mutations are more specific for some drugs. This is a case, for instance, of mutation at position 36 or 54 for telaprevir, boceprevir, and also the famous Q80K substitution, which is essentially seen as conferring resistance to cimeprevir.